Are you curious about discovering ways of making your life better? Then welcome to my podcast. I'm Bob Nickman, and this is The Exploding Human. Listen in while I talk with all kinds of people in the fields of personal growth, health and healing, alternative therapies, psychology, spirituality, environment, and the future. I'm looking for those answers that make life better for everyone. You'll meet cutting-edge practitioners, doctors, artists, filmmakers, business people, and those who have overcome challenges. The brave, the curious, anyone who is out there helping us humans to explore, expand, and explode. Today I'm going to be talking to Dr. Sheryl Lewin. Sheryl Lewin is a pediatric plastic surgeon who works with a condition called microtia, which is, if you've probably seen this, people that are born with either an out an ear or a very small ear or slightly deformed ear. Mostly this is a condition that occurs in certain countries in Central America, which we're talking about in the episode. And Sheryl began her career as a her college degree was her first college degree was in architecture, and then she later switched to medicine. And one of the interesting things I found was that she said she found her architecture degree far more valuable than the pre-med requirements she had to take in order to get into medical school. So she really is not just an MD, but an artist. This is a life-changing thing she does and changes kids' lives. And we talk about all that and how she got started and what her practice is like. So please listen in. This is Dr. Sheryl Lewin. Microtia.
Yes.
And obviously micro means small.
Yes.
And
Osha means ear.
Osha means ear, like otic or...
Yes.
Yes. Okay, so it means
exactly.
Smaller. So if you've seen people with either very tiny ears or a partial ear or even sometimes no ears. I guess there's...
Correct.
Yes, there's four...
grades.
Grades.
We call it grades of microtia, yeah. And the first one being really just a smaller than normal ear, and then progressively the severity worsening to the fourth grade is nothing. So there's no ear canal, and there's no evidence of any type of an ear. Those are a little more rare, but the middle two are sort of grade 2 being a half of an ear, the lower half usually, and with or without a canal. And the really common one would be grade 3, which is a little nubbin of what you might, of cartilage with skin over it, and a little tiny earlobe. And we use all the tissue that is there, the little bit of tissue that's there, to help us in creating a new ear.
So the people, obviously, if they're born without an ear canal, they can't hear because there's nothing there.
It's very muffled, and they have what we would call a conductive hearing loss. So although they cannot hear on that side, the inner ear is almost always perfectly normal.
Oh.
And so just the fact that they don't have a canal is the problem. So they can hear, essentially get a normal audiogram, which is our measurement of hearing that we know how to do in medicine, by using what's called a bone-conducting hearing aid. And so if, for instance, a child is born with both ears without ear canals, within weeks they will get one of these aids and be able to grow up with normal language, which is pretty spectacular.
So they really aren't deaf. They just don't have the
correct
there's no ear canals, so there's no connection between the outside world and the
correct.
Hearing.
So instead of sound coming through your canal, stimulating your eardrum or tympanic membrane and the little bones of your, they always call the anvil, all those three little bones of your middle ear, the bone conducting hearing aid gets the sound, turns it into vibration, taking that sound into vibration of the bone, and then that stimulates the inner ear, which is the cochlea. That's what may not work in someone with sensory neural hearing loss or deafness, but it's perfect for these kids, and so it goes on to stimulate the nerve and they hear sound. Now granted, it's not normal sound that you and I hear with two normal canals, but it is enough that they, can do extremely well.
So it's a condition that you see obviously at birth.
Yes.
Right. It's a genetic condition.
It's not a genetic.
It's not. Okay. So
it would be called a congenital condition, meaning it is seen at birth. However, the genetic component is quite small. Worldwide, it's probably only 5 or maybe 10% genetically inherited from someone else in the family. And mostly what I see, the overwhelming majority, nobody else in the family had it. So it's really just occurring for an unknown reason. We do not know the cause for this condition.
I just assumed it was a genetic, recessive gene, I guess.
Right, and it's not that. It's like many things that we see in craniofacial plastic surgery, which is dealing with, sort of deformities, for lack of a better word, of the head region. Some of them are truly genetic, but more of them, we don't know why they occur, and they can occur spontaneously, and then you can have other children and you don't see it again in the family. And so, unfortunately, it's rare. So 1 in 6 to 8,000 babies will be born with this. So even here in American healthcare systems, many times the baby comes out, nobody knew this was going to happen. Nobody even knows the name of it. Nobody's ever seen a child with this condition, and it's highly stressful for parents because they really end up having to go to the internet to get their healthcare information in some sense.
Well, I remember doing genetic testing with my kids, and there were so many of them, and of course my wife was scared, so she wanted to do all of them. I don't even think you can do all of them. It would take but there was so many. I had never heard of this stuff, and all it did was scare me.
Yes.
And I guess there's predispositions for certain, like in my case, being of Jewish heritage, the Tay-Sachs
correct
is one that's much more common than other ones. So that was one that we tested for. But there was a bunch of other ones, and I know there's certain things they test for more commonly.
Yes.
But you wouldn't see this in a genetic test, and you would you see it in an ultrasound at a certain number of months?
It's if you were specifically had a reason to be looking for it, you probably could see it with a really good ultrasound tech. But since nobody's looking for it, no. Well, it's almost never. I'm trying to think if I've ever had a kid diagnosed before, and I don't think I have had one.
Now, are there? This is seems to me like an odd question, but my mind works this way sometimes.
Yeah.
Do you ever have an adult that comes in that didn't have anything, treated early as a kid, and all of a sudden they're coming in at 30 years old, going, I heard you can give me a prosthetic ear? Is that
about 15 minutes ago was my patient for tomorrow, who's 52, and he's having this surgery done.
Okay.
And his case, so sometimes I get, adults that have had nothing done, but more commonly, as in his case, he's had previous surgeries that were unsuccessful. Now, he had them so many years ago, the technique he had doesn't even exist anymore. So we are doing the technique I used to, first we're removing what was placed in there, and then we will build a new ear from scratch.
Let's talk about that then, since that sort of naturally came to that. How does that? Obviously, there's two pieces. There's the plastic surgery piece of the prosthetic ear, and then there's the hearing piece with the hearing aid.
Correct. So, although we can do both at the same time, there's a surgical way to get hearing that is apart from that hearing aid. That is not a surgery I do, but is done by a very special otologist. Not everybody's a candidate for that, but it's rebuilding the canal, so to speak. The one that I do with this bone anchored device, it's actually quite a simple operation because you just take a small titanium implant, drill it into the skull with this very well worked out technique, let it heal, and then you can put this processor on outside, and that will allow the hearing. But most of the day is actually spent, and in this case, this gentleman's not having the hearing portion done. He's having the creation of the ear, and that surgery can be anywhere from 8 to 12 hours to make an ear. It's a long day.
Yeah,
It is.
And how many people are on the team when you're doing that?
I'm the only surgeon.
You're the only surgeon. You have some.
It's a
help.
control thing, actually. Like I don't.
Oh, okay. I get that.
I don't have
You're an artist.
helpers. I do view it that I'm an artist. I mean, I did have art in my background, and I feel like the first half of the day is technical, surgical, things that have to be done. But really, the last 50% of time that is spent making this is a bunch of decisions that are design related and outcome related. And for me, the outcome of the ear is you would like it to look like the other ear, or like a natural ear. But, that takes me a long time to do.
Well, the videos that I saw, and maybe we should give I saw these on YouTube. It was under Earicles, Earicles is how I was able to watch that.
Yes.
I could not tell the difference. I mean, I didn't. Obviously, I wasn't there up close. I was on video, but I couldn't see the difference between the normal ear and the prosthetic ear after whatever period of time it took to heal.
Right.
I couldn't see a difference, and I doubt anyone could. I mean, unless they were.
That would be our hope. Would be that really for these kids and these adults, you and I are talking a few feet apart. And I would like you to be able to have a conversation with someone at this distance where nobody questions or is staring at, quote, what is wrong. And if I achieve that, I feel like that was the goal. It's challenging because for, one of the reasons it's this long is, you sort of have to do, this technique in particular, I feel 100 things really have to go perfectly.
That many?
A lot of things.
Wow.
Meaning, it's just, you're there for that many hours, you're doing something. And really, it just, if you do primarily what I call the flap harvest, which just means there's a so-called man-made implant that's sculpted to look like the other ear. In a way, I find that the easier portion of the case. I stare at the other ear, I sculpt it to match. It's very fun. I enjoy that part a lot. Yeah. But the technical part that really has to be flawless is the covering of that. Because your body really wasn't meant to have a so-called piece of plastic. It's not plastic, but this implant is not a natural part of your body. And so it needs to be covered 100% with a natural part of your body that has great blood supply. And that's the tricky part, is getting that done just perfectly. And
where does that come from?
Excellent question.
Other part of the body.
Right nearby where your ear is positioned, underneath your hair follicles of your scalp, exists this membrane that doesn't really have a function, much like your appendix doesn't really have a function, and if you have it or you don't really know. But it is this well vascularized membrane. It's a living, almost translucent membrane, super thin, such that if you wrap it around a solid form, it will take on that shape. And then it's such a good blood supply that you can put skin on top of it, and that skin will have life. So we take a skin graft from another part of the body, like a male, we take the arm, a female, we take the tummy.
Okay.
And then that skin is put on top of this living membrane, and by the first week when I look at the ear for the first time, it's already pink with blood vessels growing into it. I mean, it's crazy that it works. It's very cool. I marvel each time.
I mean, it really is unbelievable. It's futuristic, but it's here.
Yes.
Is that something that was relatively new in the last, 20 years that this was discovered? What's the metamorphosis of this technique?
Yes, so this material is called porous polyethylene. And there really isn't another material just like it, in my opinion, today. I don't see any other implant that you can create into any shape. It's got these tiny, tiny holes. The holes were designed to be just the proper size to encourage blood vessels to grow within it. So unlike any other implant I can think of, like unlike a breast implant or a hip implant or a dental implant, none of those things does your body sees them as foreign and builds a wall around them. Always. This implant, your body grows into in a process we call tissue integration. Literally, the body's tissue that surrounds it grows into these holes, and it thinks it's part of your body. And because of that, we believe it will last a lifetime. It's been used for, I would say, I think 30 plus years all over the body. But as an ear implant specifically, the first one was in 1991. So we have history since then that it lasts.
15 years.
It's 20-something years, 25 years.
Oh, 20, yeah.
Yeah, I mean, it's really, it's really quite a long time now, and I'd say the last 5 years have been really a big advance. So the technique's been around, but we've really honed and refined, and for me, that's the really fun part is, even though I'm quicker on the technical side over time, I think I spend just as much or more time on the art part, and that's the part that I don't know if I'll ever so-called master, but it's the fun of keeping you challenged and interested in, pushing the envelope to do better each time.
So, yeah, I was reading that, and I don't know if this is an outdated technique, they were talking about removing cartilage from the ribs to make these ears. Is that an old technique that's not being used now?
That's a very interesting question. So 98% of the world does that technique. Now, my opinion is it's outdated, but I am the black sheep of this world
I'm
of
so
hair
happy.
reconstruction because there's just me and a few others out there that are big believers in this. And there's some historical reasons why. So the inventor of this historically tried doing these rib cartilages and was unsatisfied with the results. I, too, did the same thing. I tried to do this cartilage technique, and although there are masters of plastic surgery or microtia surgery around the world who do beautiful work with the rib cartilage technique, the concept of removing 3 or 4 of your kids' rib cartilages and then using a material that, although it is cartilage like your ear is cartilage, it's really nothing like your ear cartilage.
It's a different
thick,
consistency.
It's meant to protect your lungs. In order to keep its shape, it has to stay thick. So, in my opinion, you can't get as realistic an appearance with this rib technique as you can with the more kind of well-controlled implant technique. But the reason throngs of people are not running to do this implant technique, what I call PIER, P-I-E-R, which just stands for porous implant ear reconstruction. People aren't running to do it because it's hard to be successful. It's legitimately incredibly challenging to do it successfully time and again. And when there's problems, the problems are harder to fix than with the other technique. There's not really a way around that. So it's this funny paradox a little bit of, I do think it's a better technique, but in a way I think it's a better technique if you have the opportunity to really dedicate almost your whole career to it. I'm that over the top about it because, I'd say it took me a couple hundred of these to get super comfortable with this anatomy.
It's pretty amazing that I'm always fascinated with the people that pick one thing in their life and they get so great at it and they just keep it, and it's just, it's some sort of a calling that people have to do this one thing. Sometimes they're the only ones that are doing it, and sometimes there's only a couple, and it's just, I always wonder what. It's like you started it, and what happened that you were so enamored with continuing that?
So,
and was it a personal thing?
I think that's so funny because, had you asked me 15 years ago, would you ever focus on just one thing? I'd be like, no, I love all of pediatric plastic surgery, which I do. I love the challenge of cleft lips, cleft rhinoplasties. And I remember, I'll tell you a tiny story. When I was a resident, we went up to Santa Barbara to meet with this very famous, world-famous rhinoplasty surgeon who did, nose surgery. And I'm watching him, and it's quite an amazing experience. It's this famous guy that we get to watch in the OR and then talk to afterwards. And he sat us all down. There was 3 other kids with me. And he said, well, when I finished my training, I realized I had to make this decision. I either had to focus on eyes or noses, but there just wasn't enough time to do both. And we all looked at each other like, what is he talking about? We operate on the entire body in our training. And I thought that was kind of crazy at the time. I didn't get it. But after my training, I guess I realized my calling was, this is something that you have to really focus on kind of completely to be able to get the type of results I was looking for.
So what he was saying was to do something at a level of excellence. I think that's really what he was saying.
Yeah, it's just such a tiny part of the body's anatomy. An eye or a nose or an ear seems like a lot to focus on for a whole career. But it turns out noses and eyes and ears are actually 3 of the hardest things to operate on for a plastic surgeon. They're just a lot more complicated anatomy going on.
So when you make this prosthetic ear,
yes.
you're not making it, someone else is? You're taking a mold of the ear
You draw the opposite ear, which you're looking at. So you can see you have your perfect 3D model in reverse, typically, because we're usually a one-sided condition. Rarely it's both sides.
Yeah.
So then you have a 2-piece implant that you can configure and customize to the shape. So I have a rim, and then I have a base, and I literally carve and solder them right there in the operating room.
And this is the artificial material?
Yes, the polyethylene or porous implant. And so this implant is created. I can control projection and size and width and the 2 different pieces to each other. And so I have to take into account the thickness of the flap, the thickness of the skin, the age of the patient, because if it's a 3-year-old, I have to make an adult-sized ear, so I have to incorporate what I know about how ears grow over time.
Oh, so I didn't even think of that.
Because the implant's not going to grow.
Right. So for a while, one ear is going to be bigger than the other.
Yeah, it's hard to perceive, but in a 3-year-old, you will see. It's about a centimeter bigger.
It's not a huge difference.
No, because they're already.
They always say the ears grow after people die. Is that true?
What?
I've heard that somewhere.
No.
Maybe it's just that their head shrinks.
The lobe, as you age, the lobe definitely, like your earlobe 20 years from now is going to be a lot longer than it is. And your tip of your nose, drifts downward.
Gravity.
But something to look forward to. But no, we can predict, for the majority of your life, the size of your ear. And so the implant will be that size, and then all the work to cover it with this living membrane and skin goes on after that.
And we were talking before we started about certain parts of the world have more of this condition, or you were saying
yes.
Central America had more?
So, yes, Latin America in general has a pretty high percentage, but one country in particular is thought to be amongst the highest, which is Ecuador. Asia as well has an extremely high percentage. So I've traveled to China, and I've traveled to Ecuador and Colombia and Mexico, and given conferences to sort of help educate folks, because in these parts of the world, this type of surgery isn't done. The rib cartilage is, but this newer technique of PEER is not done. And so I have a fondness for Ecuador in particular, just because they are this tiny country, and they have the highest per capita population of this condition. And so I have a great number of patients from there as well. But really, it's so fascinating. I wouldn't have ever predicted this, but the internet explosion has changed my career dramatically, in that a good half of my patients come from outside the United States, and they find out about me, believe it or not, on Facebook, Instagram, Twitter.
It's a small planet now.
It has become very small. Yeah. So it makes for a pretty amazing and unique career. now I have friends all over the world that I do have kind of a low volume, high intensity practice. And so the beauty of that is I keep up with my patients for
Years.
ever and ever and ever. So, I'll, wherever I travel, we will find a patient that we have treated that will enjoy spending some time with. It's sort of like this tremendous extended family. And there was one other benefit, which I think your daughter, as a woman going into medicine, or for any young woman going into medicine, there is this palpably difficult thought process that you go through if you want to have a family and you want to have a career.
Yeah, I could see that being a real tough one because of the amount of time this
Yes.
all requires and the years of commitment.
It is. It is a. I think I'm the only kid of parents who, when they found out I was leaving architecture to go into medicine, they were sad. They were like, "Oh, the sacrifice. What about your kids and such?" But so that is a real issue that we all, sort of female surgeons in particular, surgeries is not a super easy specialty to allow for family time. So there's some guilt over that, but you do find, and especially even when I started a private practice where you have a little more control over how you spend your time, the way that I was sort of able to work a lot of hours but still try to help with my family life. I have 2 kids that I had in residency back to back, and so they were kind of grew up with nannies, and my husband doing the brunt work of parenting in those early years. So this practice that I have I've just brought them into it. So I brought them into my nonprofit, which is Earicles, and they come to every single educational conference we do. They travel around the world and see kids from other parts of the world. They come to clinic. They meet my patients. Many a patient has come to the house for a post-op visit. And interestingly and surprisingly, getting them involved in what I do, all of a sudden, their compassion and ability to understand, well, mom's not here all the time, but look what she's doing to help others. Yeah. That somehow translates. And, I always think there's always a flip positive side to the negative. You just got to find it and work with it.
It sounds like they get to see a lot of gratitude from a lot of people.
They do.
And what that means.
They do, for sure.
So let me go back to something you just said about you were in architecture school.
Yes.
And then you decided to go into medicine. It seems, I mean, I know you're doing artistic things and those kinds of things in your practice now, but what was why architecture and then why not architecture?
I feel like I didn't have a particular affinity to science when I was growing up. I did love art, all forms of art, sculpture, painting, drawing, pencil, whatever. And so when I went to college, I had no idea what I wanted to do, despite the fact that I grew up with a mother who was a nurse and a father who was an architect. I had no interest in either.
Okay.
I mean, I didn't believe I did. I didn't quite understand buildings and what was going on there, but clearly respected what my parents did, but just came with a very open mind, as I was told by them, just go to a liberal college, try everything you like. And I surprisingly fell into environmental design and loved it, to my parents' great surprise. And then I just went with it. I loved design. I loved 3D problem solving. And what happened is where I went to school, it was a very theoretic architecture training. There was no computer-aided design. You got to draw everything. So I was like drawing and painting and sculpting every day.
So they weren't using computers at this time.
No,
right.
I'm old.
Yeah, no,
older. So I liked that. I was going to college, get a degree. I can do this as a profession. I can help teach other people. That's what I thought. I would get a master's and teach architecture. So I completed my college, and in my last semester, I had a conversation with my husband, and I said, I'm a little concerned about grad school. And he's asked me why, and I'm like, I just don't know if this is like what I want to do with the rest of my life. Like, this is going to be what fulfills me.
So there was an inkling somewhere in there that it just wasn't quite it.
There was an inkling, but then I said, but it's too late because I just finished college and we need to get going here on a career. So I remember him saying to me, I don't know why you never tried medicine, because honestly, you would be a fantastic doctor. And he picked up the phone. This is my husband. Picked up the phone, called UC San Francisco, said my wife, well, I was his girlfriend then, is about to finish college. She's taken no biology or chemistry or anything, any pre-meds. What could she do if she wanted to go to medical school? Is it too late? And they said, no, just down the street from you guys is a post-bac program. You can spend 2 years doing that and get all your pre-meds done. So I actually did that.
Does that still exist to be able to do it that way?
Yeah, it does exist. There were people there that wanted to go to med school or vet school. A lot of vets, too. And so I finished this program and applied for medical school, and it just snowballed from there. So
I always assumed, just because my daughter's going to college and she's telling me about all the pre-med stuff she has to do in 4 years. It's
a lot.
It's a lot, and it doesn't seem that much fun, but I know she likes it. Yeah, she likes it, but
it's hard.
It seems really hard.
And it's harder now than it was then, and much more competitive. I mean, it was pretty competitive then, but it's rough. I mean, it's definitely hard to get all the way through medicine. And then, similarly, the rewards with the way healthcare is changing and what an individual physician can get out of their career, that respect and autonomy and doing the right thing for the patient and all those things that you love. You're kind of constantly fighting a bit of a battle, just getting through the day of all your responsibilities now, and not being able to deliver health care in the way you might want to. And probably one of the neatest things about what I do is I'm a little island, my own little practice, and I can control every little aspect of it for the most part to give the care exactly as I want.
Yeah, it's interesting. I was talking to another doctor that I went to see for something, and I was telling my daughter wants to be a doctor, and he was telling me all the different disciplines that she shouldn't do because it's so difficult.
I would agree with
don't
that.
Tell her not to do that.
I would agree with that.
I don't even remember half of them.
No,
what about a pediatrician? No, you don't want to do that. And he goes, insurance is absolutely killing what I can do.
Correct.
And they vary what they pay depending on which company it is. He goes, and the paperwork and the legal stuff. He goes, I really can't spend the kind of time I want on my actual work.
Patience, yeah.
And you hear it a lot, and it's
you do.
And is it going to change, or is it going to become more complicated and more difficult? It seems like the more corporate it gets, the more money involved, that it's going to be harder on doctors.
I think that's probably true. I think there were 2 pieces of advice I was given as a medical student, and I would pass that on to somebody who, but I think they probably hold true still. To somebody who's interested in this field, which is, don't go into medicine unless there is absolutely no other career you could see yourself being satisfied in. It really has to be the one and only. Because if there's an alternative, that's probably a better alternative. But 2, I think it was a female neurosurgeon told me this. So it's great advice for a med student. Right before they have, a couple years to see medicine to make their career choice for the rest of their life. That's a big and weighty decision. And so this neurosurgeon sat me down and she said, you're going to go around on all these rotations and you're going to talk to all these doctors that do incredible things, and the heart is amazing and the liver is amazing and the kidney and ortho and all these things are pretty fascinating, and everything you do you're going to get really bright-eyed and excited about because there's something spectacular, transplant surgery or whatever it is, some infectious disease and what they can do now, or cancer research. So what she said is, look around and find what the bread and butter is of all of these specialties, which is typically not very exciting or fun, and say, what's the one of those that I can most handle?
Oh.
And
Okay.
it turned out that, clinic for a surgeon, I love clinic myself here, but when you're training, clinic is you're just itching to get in the OR, and you're like, clinic, come on, let's get through it. But the clinic that I had the most fun in, compared to all the other kind of surgical clinics that I went to, was clearly plastic surgery. So it sort of was a natural fit for me, and kind of fit in clearly with the visual elements of that type of surgery. I mean, you get to see your results, unlike colorectal surgery or
You don't get to
lung
see it.
surgery or something. You get
Or you don't want to see it.
That is probably true. Yeah.
Yeah, come on in a couple of years. Let me take a look. So the how many do you do of these a year?
So I average about 3 a week.
Really?
Some
So
weeks.
3 12-hour surgery days.
Tuesday, Thursday, Friday.
And then you've got, and how, when it's healing, I was looking at some of the pictures of they're red and they're swollen and how do you know it's healing the right way? I mean, it's just experience because it's so big and funny looking.
It is big and funny looking, but you get used to how things look when they're, in those early days. And I have those videos because you don't want a parent to think, oh my God, I made a horrible decision doing this. And then patience is the name of the game. And so really educating everybody beforehand what the future holds for them in this little time point of their life where they're dealing with this ear is really important.
And the process is how long from when, let's say I know there's a process up to the surgery, but the day of surgery, when is the healing generally? What's the window of completion till they look?
So they look crazy at the 1 week when they see their ear for the first time. And then I'd say for a young child that heals pretty quickly, by a month it looks sort of like an ear, a swollen ear. And by 2 months it looks a lot more like an ear. And by 6 months it's done changing. Skin is...
That's a lot faster than I would think.
Yeah, adults a little bit longer. I quote them a year to complete healing.
And there's bandages on just up to the first week? Or do you
No, we'll protect it for 2 more weeks. So 3 weeks of protection for a kid, 1 week for an adult. They're much more responsible. And then, you just protect it from the obvious, maybe 6 weeks before you're back to swimming and exercise.
That's truly amazing. What has there been, I always think about how kind of nasty kids can be to each other. I mean, just like adults, actually. But
true.
Some of these kids,
and adults can be nasty to kids too. Believe it or not, I hear that.
Yeah, that's
it is the worst.
So I'm thinking, some of these kids have probably been teased or ridiculed or called, especially maybe even in other countries where it's not quite as
very
accepted to recognize people's.
Very astute observation, for sure. Other countries, the bullying's very significant. I mean, beaten up over this or kept in the house and really horribly life-changing in a negative way. Obviously here we are very good at avoiding, physical bullying with conditions like this. However, the psychological component, in my opinion, cannot be underestimated. And one of the saddest things I saw pretty early in life is I used to dictate in my notes about these kids the psychologic issues that they were having, or if they were teased or bullied or whatever, we'd ask about that. And I came to learn that is specifically not an indication for coverage with insurance. So I took out all of that from my notes because it almost was a negative by saying there would be a psychological benefit, which is absolutely contrary to every kind of healthcare, whatever you would say that would help this kid. If you could get them mentally in the perfect place, that will solve so much future potential need from the healthcare system, obviously.
Yeah.
And so it was so obvious that what I'm doing is not about making this ear. What I'm doing is about making this little person feel whole, feel like everybody else. And just this surgery, even though they're so young that you don't think they can really conceive of what is going on, or you almost don't think they could even care. many surgeons will say, why would you operate on a 3-year-old? They don't even know they don't have an ear.
Yeah.
It's not true. That goes to the thing about kids being much smarter and teaching me. They clearly know. And then more than that, they do get such a benefit that became something I became very interested in studying and have published several papers on the psychologic effects, the positive effects of doing early surgery so that kids didn't have to face
less years of being tormented or feeling bad about themselves.
And the confidence, it's hard to measure that. Your daughter might have seen little glimpses of it, but it is almost like an instantaneous change in personality, slight, but these parents say, you know, my kid walks taller. One of the funniest stories was this mom calls me and she said that her kid, you know, got a surgery before kindergarten and he was coming into his kindergarten class and she said he walked in ear first to tell everybody, look what I did over the summer. I got me an ear. It's very cute. You know, they're so little at that point.
Well, I just, even little things, I was just remembering when, my sister had a little red mark, a birthmark on her arm. It was tiny.
Yeah.
Really small. Broken blood vessels, whatever. It was, like 2 little things on the inside of her arm, and it bothered her, and she felt really bad. She brought it up all the time. And that tiny little thing that truly is insignificant, no one cared.
Right.
Except her.
Right. But it has an effect on her.
Yeah, and to see that tiny little thing affect her that much, how could something bigger not do that, especially when people are noticing?
Well, to me, it was so interesting as a craniofacial fellow, because I would go in the room and I would see a child with a cleft. So clefts, as good as surgeons are today, have a scar of their lip and a distortion or asymmetry of their nose. And when you meet someone with a cleft, you often know they probably had a cleft and had surgery. And then I would go into the next room and see a kid who had microtia, missing ear, totally normal ear on this side, missing but long hair, perhaps like mine. And you honestly would walk in the room and you would never know. And I was sitting there trying to figure out, why is it that the kids with microtia are so more withdrawn, so more emotions on the inside?
Yeah, that wouldn't make sense because visually the other people aren't noticing it. Okay.
So do you have the answer?
Oh.
Putting you on the spot.
Well, the only answer I would think of is that they know and they're hiding something.
That's the answer.
And they're feeling shame.
That is the answer. So until you actually have no ear or have a loved one with no ear, it is so hard to put your position in what must life be like. If any one of your listeners had a child without an ear, like how does life change for them? Well, then you interview these kids and you realize the girls, they won't swim because the water might reveal their ear. They only hug on the side of their good ear. Windy days stress them out. I mean, think about how many decisions in a day to hide something from the whole world.
Well, that's a real tension. If you can't hide it, you get used to not being able to hide it. But if you're able to hide it, then you're going to do that, and you're going to have this heightened, almost hyper-vigilant kind of
stress about it. Like, just think of your sister's little red mark that she could hide pretty easily, but it still bothered her a lot. So you just have to magnify that. And then, of course, when the wind blows or the swimming occurs or the hug reveals this, there is the shock of someone finding out your secret, and then the teasing that occurs afterwards. So it makes the whole thing cycle worse. So I am a big proponent of, taking care of these kids when they're little before they feel like they even have to hide it. When you're so little, all the boys have short hair because they're so little,
right?
Whatnot. They don't get what the stares and questions are. But so it's nice that if you can prevent some of that heartache for the parents who already feel guilty that this happened even though they did nothing. You help this family, get to help this family unit as a whole get past this, and then it just gets forgotten that they were ever born without an ear.
Yeah, I was thinking about because one of the videos I saw, there was a sibling there too, and I'm sure that affects the siblings too.
Absolutely,
it's like a family. I hate to use the word shame, but it kind of is, and even though they haven't done anything, it's like a secret, or it's the thing we don't talk about, or it's the thing we don't like, or...
I think it's much healthier to do the opposite. So we try to teach, like, I don't ever say I'm fixing anything. For a little tiny kid who doesn't understand, I kind of use an analogy of a little plant. It starts out as a seed, and it's a little tiny baby. It's tiny, and I just kind of help water it and help it grow into something big. But I use all the parts of the little ear. We don't throw anything away. And that helps a kid understand. But for a family, so again, as I mentioned to you, I like to be a cup half full type of person. And so when I talk, there'll be, parents of newborns that want to have a Skype consultation, and they'll be devastated that their 3-week-old was born with this condition and they don't know anything. And a little part of me tells them, feels the need to tell them that after we've gone through the whole, this is what your next 3 to 5 years will be filled with, and we're here to help you, and we'll walk you through this journey, and blah, blah, blah. And you sort of tell them the nuts and bolts of what has to be done. Then I say that I know you're in the depths of sadness about what has occurred, which is very rightful, and everybody goes through. But I have this crazy, unique experience of meeting and getting to know hundreds and hundreds and hundreds of these children. And I will swear to anybody, they're special. There is something so incredibly special about these kids. They are so empathic. They want to grow up and have fields that help other people. I mean, I see it because I get to watch them grow up into, kids going to college and such. And so I say, even though right at this moment, all the thoughts are bad, that look what has happened, look what we have to deal with, this is terrible. It's true. It is a lot to deal with for these families. They understand it's not life-threatening, but it's stressful.
Yeah.
But there is this little positive that they will meet other people, they will have experiences, they will do things that they never would have done had their child not been born with this. They will travel to places they have never been. Otherwise, they wouldn't have come to. And so I get that at my conferences. I'm 1 week back from Nashville, Tennessee, where we had 67 families all in one place, all with this condition. It is crazy cool what happens, like kind of the magic of just putting all those people into one place. And they create these friendships cross-country, cross-nation. And it's an interesting thing. So there's this little part of it that I think these kids, I mean, maybe it's my bias for what I do, but I do find them to be incredibly special.
But that must be just an amazing thing to know. You have the shock of this thing that's happened, and then all of a sudden you're talking to somebody who is saying, yeah, it's kind of bad right now, but it's not going to be that way forever.
Right.
There must be a sense of relief that's just...
There is.
That kind of hope is just, because, I would think, 50 years ago that might not be the case. Or
Correct. It's cute. Like I remember last Friday, which is not that long ago, I operated on this little 3-year-old boy, and I spoke with them when their baby was 3 months old for the first time, and then we've kept up and we talk once a year or whatever. But I mean, I saw pictures of this little guy when he was a baby, and then I met him when he was 1 and 2, different parts of the country we would meet. And, it's kind of neat to come full circle now and give them an ear. It's an emotional day for the family, as you can imagine. But it is it's pretty great.
So you do have to wait a certain amount of time before you can do it. Obviously, an infant is too young.
Too early, yeah. So 3 years is the earliest we would do. And then anything up, as I said, 52-year-old tomorrow. So it's wide-ranging. And so it's interesting to me a little bit that, going back a little bit to that psychologic effect, because there were not good solutions for this condition 20, 30 years ago. There was a solution, but they weren't where they are today. So my nonprofit is actually dedicated, honestly, to failed ear reconstructions, because it's bad enough to have this condition, but then to have someone who maybe shouldn't have been performing the surgery, or that the surgery had some terrible thing happen, and now you are worse off than had you never had surgery. People try to fix it, you end up worse off. And so this, type of technique is kind of what we call the salvage operation. So we can kind of fix any other failed surgeries with this technique, which makes it really universal. It's nice in that way that you can. Those are the patients I think that are the most grateful. The parents are horribly guilt-stricken that they did their best to get their kid.
Tried to help.
Yeah, and they ended up.
They have that horrible reality show called Botched.
I've never seen it.
Oh, it is so offensive.
I've heard of it.
The idea of it, because it's really voyeurism on botched surgeries. I mean, it's good that people get fixed, obviously.
Yes.
But I was just thinking about that when you were talking about it. But what that must feel like. You're trying to correct something, and then all of a sudden it's going the opposite way.
Correct. And so it's nice to at least be able to offer some hope for those families, certainly.
Now, here's a question that I was just wondering as you were talking. Do you still do any kind of art? Do you have time for that?
I do art, but in small doses, I would say. So around the holidays, I am always take time off, and part of my, meditative time when I have time off is going to involve drawing, painting, or sculpting. And then in my household, instead of gifts, or primarily instead of gifts for things, we make things. So for all my kids' birthdays and holidays, I am doing little artworks or little creative things. Those little projects are fun, and they keep me going. Right now, I have the neatest thing I'm doing, honestly, sentimental for me, which is my father, who's an architect. He is helping me because I happen to be opening a brand new office and remodeling a home at the same time, and he is my architect on both. So we're working together every day.
How wonderful!
Back in architecture again. It's pretty cool because
so he has a client that knows almost as much as he does, which is annoying. And it's his kid who he wants to please.
What's funny? It's so funny that he and we have identical taste, in all of this, and so whatever ideas he comes up with, I love, and vice versa. So it has worked out to be a really nice, fun time, So that's pretty cool. Plus, he's designing where he's going to stay with us, so he gets his room just how he wants.
Well, that's nice. Yeah, he built him the father-in-law suite.
There you go.
What's this room, Dad? Oh, this is where I'm going to be staying.
Yeah. I got everything I wanted here. So, yeah.
Well, thank you so much for talking to me.
Thank you. It was a pleasure for me.
Yeah.
I hope you enjoyed that podcast, and check out her website, or actually look up. It's called Earicles. If you want to go on YouTube, Earicles, and you can see a video of exactly what Sheryl does, and quite beautiful to see these young kids' lives changed. And her work is tremendous. So thank you for listening. And if you would like to contact me, it's bob@theexplodinghuman.com. Send me an email. Or I have a Google Voice. I hope that works well. I haven't really tried it yet too much. I set it up, but I haven't really used it. 424-272-6396. Tell me what you liked, what you didn't like, maybe something you would like to see, somebody you'd like me to interview, topics you'd like me to cover. I'm open to all of it, body, mind, and spirit. That's the territory we're covering here on The Exploding Human, and thanks for listening in.